Hello, everyone. I'm really excited today that we have Dr. Justin Young back with us to answer some questions related to sexual health topics. And we know that this can sometimes be an uncomfortable conversation, and we're here to help dismantle stigma and to empower you to go have these conversations with your primary care provider. And Dr. Justin Young is the Regional Clinical Director for Southern California for Carbon Health and has years of experience in both urgent and primary care. So I'm going to turn it over to Justin to just give a brief description about a very common question that we've received. What are the differences between an STI and an STD?
Most adults, I think 1 in 2 adults by the age of 25 will have had a personal experience directly with an STI. Obviously, this is a timely topic. It's always at the front of mind, and always honestly, it's one of the common reasons that people come into our urgent care clinics and our primary care offices when something burns, they notice a rash, or just this routine screening when it comes to our own general sexual health. So it's really important to kind of have these conversations. It's really important to have these conversations with your physician, and definitely important to make sure that you are in a space where you feel comfortable discussing all of your sexual health needs, particularly just feeling comfortable and open, having the conversation about what your sexual history, is. I think one of the reasons, to answer your question about the difference between what is an STI versus an STD, there's been a lot of stigma that was associated with a sexually transmitted disease. And to be completely honest, one of the ways that we kind of approach it is that sexually transmitted infection, or STI, is probably, one, more accurate. Two, is kind of the more appropriate, and I don't want to say modern way, but kind of is the more modern, progressive way of approaching these types of infections that befall many adults across the globe. So the STD connotation carries a little bit more of a negative stigma, but in the clinical sense, the STD, or sexually transmitted disease, is when an infection persists long enough to actually cause a disease state that disrupts the normal function of the body, so on a more chronic or ongoing basis. So the likelihood of someone contracting a disease just doesn't really fit for what these types of infections are. Even the types of infections that are incurable, that a person would contract from one partner to another during a sexual episode, the term disease in that moment is just not accurate. And so historically, the negative connotation that was associated with it is just not helpful, not accurate, and the stigma associated with limiting our patients' ability to really open up and communicate about what their needs are just doesn't really have a place in the healthcare setting. When a patient walks into the room, or when I have a conversation with them, whether it's virtually or in person, it really is important for them to be able to feel comfortable talking about what their medical needs are. Honestly, what it boils down to is the medical history I don't know about can really harm a patient and limit my ability to provide them with the best quality care. So I want to make sure that the space is welcoming and honest and open. So basically, that's, I think, one of the ways, in a roundabout way, answer your question about STI and STD. I think more and more, that's why you're finding that a lot of healthcare professionals and doctors, nurse practitioners, physician assistants, in the clinical setting, we use sexually transmitted infection more frequently.
And if somebody is coming in to get checked out for a sexually transmitted infection, potentially, what could they expect to see in terms of the type of tests that would be done and samples that might be collected?
I mean, those are good questions. I think typically, and I don't want to assume that most people have gone in for an STI screening, but in most contexts, what you typically would end up doing is giving a blood sample, giving a urine sample, and what we would do is kind of like a little throat swab. So if you've ever, or to be fair and to be clear, the swabs could also apply to, it could be a rectal swab to check for gonorrhea and chlamydia. It could be a throat swab for gonorrhea or chlamydia. And in certain instances, if there is discharge that's noticeable, it could be a specific urethral swab at the opening of the urethral meatus at the tip of the penis. Or if there's vaginal discharge that's noticeable, a swab there as well would be collected. So in that way, you can check for gonorrhea and chlamydia in the urine sample. You can check for things like trichomonas, gonorrhea, chlamydia with a vaginal swab. And then when it comes to blood tests, typically the blood tests that you're going to encounter for HIV, and then also for syphilis. But in some instances, say for instance, a patient comes in, they've already noticed that they have a lesion or a rash or a spot that is concerning for them. We can also do a little direct swab as well to kind of determine whether or not it's what type of lesion it might be. Particularly recently, I think a lot of people in this most recent outbreak of monkeypox that we've noticed in a lot of parts of the country, swabs for that were taken as well. So it's just dependent on what symptoms a patient presents with. So it could be very specific, or if it's just a screening test, all of those types of samples would be collected.
And I love your outlook about having the patients be open and feeling comfortable talking with their physician or primary care provider about any changes that may have occurred related to their sexual health. And I'd love for you to talk to the audience a little bit about why is it even important to go and have something treated if you do end up having a STI?
Well, I think the biggest reason to do so is to kind of minimize any kind of complications or additional health problems that are associated with it. A lot of times, I think people just tend to think that STIs aren't that big of a deal. Technically, they aren't. Most are going to be curable, but I think the bigger issue is those that could be curable actually can lead to complications as well. So it's really important to think about the consequences of potential infertility. There's, sterility in certain cases if certain STIs persist on an ongoing basis, where that would impact future sexual health, right? And reproductive health and reproductive issues. So it's really important to kind of make sure that you're regularly screening, because a lot of these STIs are going to be asymptomatic, where you don't present with any symptoms, where you don't present with any signs of illness. There doesn't have to be the traditional discharge, burning, or rash. You could have an STI without knowing it. And so if you are sexually active, that's why we recommend that you regularly get tested. But for the most part, things like gonorrhea can lead to additional problems, like pelvic inflammatory disease, which can really be harmful to patients. But the other thing to think about too is just ongoing heart issues and heart conditions that can be associated with that as well. So when you think about undetected and untreated syphilis, for instance, it can lead to a number of different problems, heart, disease. And in addition to that, there are also different stages of syphilis that can kind of persist. It's rare in certain countries, I should say, where there is that appropriate healthcare access to manage a lot of these illnesses. There are certain, you don't necessarily see secondary or tertiary syphilis or those advanced stages of syphilis anymore because of conversations like this and because of management in this way. So yeah, I mean, honestly, besides the fact that you could pass this on to others and they can become ill as well, I think the bigger thing is that there are ongoing complications that you have to be mindful of. And that's why it's really important to test regularly, get treated, and let your partners know that they need to get tested as well.
So I'm going to transition the conversation a bit to a big bulk of questions that we got related to HIV. And we know that HIV has historically been very difficult to treat due to it infecting the immune system specifically, which our bodies need in order to fight off other pathogens. So I'd love for you to just give a bit of preventative measures that individuals could take to prevent HIV before we jump into some of the details related to medications.
I think it's an interesting question, and I think it's an interesting conversation around HIV. I think if we had this conversation a decade or two ago, it would have been completely different. But when we talk about STIs and we talk about stigma, I think a big part of the conversation around that stems from the fear and the isolation and the discrimination as it pertains to individual patient status when it comes to HIV. Thankfully, there have been a lot of medications in place after years of research and tons of work that we've arrived at that allow for us to kind of treat HIV more as a chronic health condition akin to diabetes, high blood pressure, and other things. It's not as much or considered as much of a death sentence as it was in the past. And we could go back to the 80s when it really was wiping through, particularly the gay community, but a number of different communities across the board. I think the stigma that was associated even with the supposed origins of HIV and the communities that were directly impacted limit our ability to really make progress with the management and care for other communities that are now starting to see rises in the rate of HIV. So I think when it comes to preventative measures, I think one of the first key pieces is communication, being open, having honest conversations with your sexual partners. And this isn't just about HIV, this is about all STIs and just general sexual health. It's important to have a conversation with your sexual partners. It's important to be tested, ideally before engaging in sexual activity with a new partner. But ultimately, that communication is really, really important and really key to keeping each other safe. Regular STI screening, as I already mentioned, is also a way to manage and be preventative, not just for HIV, but for all STIs. condoms. There are instances where, like, if there is concern about HIV exposure, post-exposure prophylaxis helps to prevent the seroconversion to being HIV positive if you happen to come into contact with or have unprotected intercourse and are concerned about potential exposure in the sexual health context. But also it's a practice that's been used in the healthcare setting if there had been any kind of exposure to potential blood or other types of like tissues that may increase the risk of contracting HIV. So post-exposure prophylaxis is one. Advances in pre-exposure prophylaxis and the medications that can be taken daily, or under certain circumstances, there are injectable medications as well that help with that as well. And it's been shown to significantly reduce the risk of contracting HIV during sexual activity. So that's another part of how we've been preventing HIV really across the globe. And there are definitely certain communities and certain parts of the world where we could do a better job of making sure there is more access to PrEP. So those medications are really, really important. But beyond that, even if a patient does contract HIV, I think one of the big things to think about is that with the advancement and with regular medications that are, taken on a regular basis and in management with your primary care doc or other specialists, there is ways to make sure that you are undetectable and make sure that that viral load and the viral burden of HIV is undetectable, which basically means that it will not be able to be transmitted. So we've come a long, long way. And again, I feel like I keep giving you these like lengthy answers, but I think it's part of like the full conversation that needs to be had is like, we have ways of managing a number of different STIs. And I think it's really important, really critical to kind of like double click on the fact that when it comes to stigma associated with STIs, especially in our lifetime, HIV was definitely one that was terrifying and still is quite horrific in certain contexts. But because of advances and because of the ways that we've now been able to approach having a conversation about how to manage this illness, I think it's really important and critical to just make sure yes, it is still out there. It is still a part of the reality for a number of patients. But the ways that we manage it definitely help to kind of minimize or eliminate that stigma completely.
Yeah, I completely agree. And I think you brought up some really great points and specific topics that the community wants to know more about. So I want to break down a couple of them. And the first one I want to talk about is, what is PrEP for a daily pill?
So PrEP is, as I had mentioned, is pre-exposure prophylaxis. So it's a medication that basically allows to prevent the contraction of HIV. So when it comes to, and it's been essentially studied in the context of sexual activity and sexual intercourse. So the two medications that are commonly out there are Truvada and Descovy. Both use a combination of medications, emtricitabine and tenofovir. Descovy, because of the formulation of one of those medications, it basically is a little bit more renally protective. So it's a little bit easier on your kidneys. So depending on the conversation that you have and what medication is available, you can have that conversation with your primary doc or even pop into an urgent care. Most urgent cares these days are equipped to be able to do, take care of the screening process to get you started on PrEP. But it is one of those medications that you have to take regularly for it to be protective and effective. I think with daily dosing, it is roughly 99% effective at preventing the contraction of HIV if you are exposed in a sexual context. So it's really important to make sure that you do take it regularly, and you are regularly testing. So the way that it works for Truvada and Descovy, in particular, their baseline testing based upon whether or not you're HIV positive or negative. Ideally, in this context, you should be HIV negative to start PrEP. Otherwise, you would be on another series of antiretrovirals or anti-HIV medications. So in that context, baseline testing, make sure that your kidney function is doing okay, make sure that you're HIV negative. We also test for additional STIs as well. And then based on that, if all is negative, we would go ahead and start you off with a prescription. And so in most cases, it's a daily dosing. You take the pill once daily, and after basically 7 days, you should have enough of the medication circulating to be protective. And that's protective for receptive anal intercourse. When it comes to vaginal intercourse, it's a course of 21 days. So basically after you take it for 21 days, it should be circulating at enough of a level to be protective for vaginal intercourse as well. And it's just a series of different absorption and mucous membranes that are associated with each area. So that's the difference there. But ultimately, after that baseline startup of 7 days or 21 days and continue to take it daily thereafter, then you're all set.
And you also mentioned a form of injectable. So what is an injectable form of PrEP?
Another great question. So most recently, I believe it was in 2021, the FDA approved a medication called cabotegravir, or the common name is CAB, but basically it's an injectable form of PrEP that starts out in a similar way where you get baseline testing for it. You have 2 initial injections that you'll get intramuscularly. So put it simply, it's a shot in the butt. And basically what it does is that it starts out with the 2 initial injections and then, 1 month apart. And then every 2 months thereafter is how that sequence goes. So instead of taking a pill daily, you would get an injection once you're ramped up. You would get an injection every 2 months to be as protective. And so the question would become well, what if I want to stop taking the injection or I wanted to switch to oral PrEP? Typically after the 2 months, each 2 months, if you go beyond the 2 months, there should still be a circulating level of CAB that would be present in circulation, but we can't guarantee beyond the 2 months that it would still be protective. And that's why you go through that sequence. So as you're transitioning, you would switch to, oral PrEP, preferably within that 2-month window to maintain that protection. But either way, you would switch if you tolerated CAB without a problem or cabotegravir without any problem. You would then switch to oral. And again, it would be kind of the same ramping. And preferably in that transition period, you would kind of give it a little time. So typically that 7-day period before participating in any kind of unprotected intercourse or what have you.
Yeah, I love that you mentioned that about a couple different types for oral. There's the injectable. This can be for individuals who maybe tolerate one better than the other or who have different lifestyles. One works best for the other. So it's nice to see that there's options available.
Yeah. And I think that's the biggest piece. We were talking about communication. I think it's important to understand what is going to work for your patient. I mean, if it's medication for hypertension, or if it's medication for diabetes, or if it's a medication for PrEP and prevention of HIV, it's all dependent on what the patient is going to do. So having that shared decision making is really critical, because the medication that works is the one that your patients are actually going to take. You know what I mean? So if it doesn't fit their lifestyle, if it doesn't fit their activity, if it doesn't fit the convenience even of what they're trying to do and how you're trying to manage whatever you're trying to manage, if the patient isn't able to kind of adhere to that, especially in this context, then there is a certain degree of risk, and we're not doing our job, right? So I think it's really important to make sure that you have that communication with your patients about what medication works for them, whether it's oral or injectable. I think it's also about whether or not the medications are readily available, right? Oral PrEP been around for quite some time, right? And they stem from medications that already existed to treat and manage HIV. Basically medications that kind of inhibit the reverse transcriptase of the viral, the virus itself, so that it basically results in DNA chain termination, and it prevents the virus from being able to kind of invade the host cell and replicate. So those medications have been around for some time. In this combination, particularly most recently with injectable PrEP, it really depends on what is going to be convenient for your patient. If they don't like taking pills, if they think that they can adhere to a regular schedule every 2 months to get the injection and that works for them, I think that's fine. But I think the other thing to keep in mind too is that now, particularly in with certain patient populations, PrEP has become so commonplace and a part of the conversation. There still needs to be that conversation about other STIs as well. So PrEP isn't a silver bullet to protect us from all things that can impact our sexual health. So it's really important to make sure that on a regular basis, we're not just checking and testing for HIV in the maintenance of PrEP, but also looking at things checking for gonorrhea, checking for Hep C, checking for syphilis, and just having a broad picture of what our general sexual health really stands at.
Yeah, that's a great point. And I want to jump to the flip side of PrEP and instead talk about another term that you brought up earlier called PEP, or post-exposure prophylaxis. So Can you give a description of that to the audience?
Yeah, so PEP basically is kind of like, I don't want to say like a modified form of PrEP, but it's essentially a way for us to prevent someone who may have been exposed to HIV, prevent them from contracting the virus. And so what that means is similar to PrEP, it's a medication that will help prevent the virus from being able to replicate. And so how it works is you start off with, again, like a similar medication like Truvada, plus another anti-HIV or antiretroviral medication that you would take daily for 28 days or essentially a month after that exposure. But the importance about PrEP is that you have to be very time sensitive about it. So it's been studied and shown to be effective within 3 days of potential exposure. And so whether they've had like a condom break or inadvertently had, unprotected intercourse, and then secondarily found out that their partner was HIV positive, or any number of circumstances that would potentially could befall an individual in that context, whatever the reason, within 3 days of exposure, if you take PEPs, it is essentially effective, almost as effective as PrEP at preventing conversion to HIV or contracting the virus.
I think that that's great information for people to have, that they know that is something out there that they can go do, and that there is people they can contact if they do have an exposure. And then kind of to wrap up the conversation about sexual health, if someone is kind of feeling uncomfortable bringing up this topic to their primary care providers, what advice do you have that they can do?
I mean, honestly, I think it's just like I said at the beginning, with any patient visit, any patient encounter, like I'm not doing my job if a patient doesn't feel comfortable talking to me about what their needs are. And so when it comes to any of these topics, like I know sex isn't an easy topic to talk about. Like I wish it wasn't such an American thing to not be comfortable about it. I mean, with any medical condition or any like medical history, what you're doing, like your doctor needs to know. And so I hope that this is a relationship and a communication that is open, that is comfortable, and even the uncomfortable topics and the uncomfortable decisions and discussions that you have to have with your doctor, hopefully you feel supported enough and welcome enough to be able to have these conversations, because that's what is most effective and most protective. And I think very common in medicine, what we're trying to do is the shared decision making, and really trying to get you to a place to provide you with information that helps you decide what is going to be best for you and your care. So I can't do my job if I'm not creating a space where you can talk to me about what you like to do sexually, how many partners you have, how many partners you don't have, what type of sex you might be having, in any given context. Like, I want to know about your kinks. I want to know about your preferences. I want to know, like, when was the last time that you had sex? What kind of sex? Who you have sex with? Like, it should be in the most non-judgmental context. Like, that's what we do. That's who we are. That's what I am as like a healthcare provider. And quite frankly, like I really think this is really critical and really important, because medicine really is about advocacy for your patients and really showing up for them in a way that really is protective, and not in a way that I'm protecting a patient, but I'm providing information so that the patient can do what they feel is the most important and most protective for what their needs are and what their lifestyle might be, and how it pertains to like the medications we need to prescribe, the treatment we recommend. And that can't happen if it's not in a space that is non-judgmental, if it's not welcoming, if it's not supportive. Then that's like half the battle right there. So like, I hope people are comfortable talking to me about it. I talk to my patients even about like my own like encounters and like experience with like just being an adult, like I think in terms of like healthful conversations, like we need to be relatable and connect with patients about what ways they can be most protective of themselves. And so sometimes just being a little relatable is really important as well. And so giving that context is really key, is really important. And I think humanizes not just like us as healthcare providers, but humanizes the medical experience in general. And for these types of uncomfortable conversations, that's very critical. And honestly, I hope patients know that. And if they don't have a provider that they feel like they can't open up to, they find one that they can, because it ultimately is really vital to their general health and well-being.
Yeah, I echo that too. If you feel uncomfortable with the current provider, I think that you can go out and find a different primary care team that you do feel comfortable having these conversations about. So I just want to thank Justin and I want to thank Carbon Health for helping us to break down some of this uncomfortableness that sometimes associates with sexual health topics. And we hope that we have empowered you to not only listen to the information that Dr. Young provided, but also go out and find more information from your own primary care team and get yourself checked out as needed. So with that, we are excited that soon we'll be talking about another topic related to sexual health, about HPV and cervical cancer in the next few weeks. So stay tuned for that, and we will talk with you then. So thank you very much.